Hey there. So this is for my third verbal soap note. Client initials are TB. Date is November the 8th, 24. Clinical site was Pineville Children's Clinic under the preceptor of Dr. Manu Bergava. My name is Kerrigan Levi, and my clinical faculty is Ms. Gail Elliott. So, starting off with identifying and biographical data, TB is an 18-year-old white female who is established with this practice. She is unaccompanied and answers all questions with a good history. She has Louisiana Healthcare Connections Medicaid. Chief complaint is STD screening, possible UTI, referral to an OBGYN. So, HPI, patient reports that she has had a new sexual partner in the last 3 weeks and was informed by a previous partner of her new boyfriend that he is not disclosing his STI status to her. Reports that she has had previous infections of chlamydia, gonorrhea, and trichomoniasis and is aware of the complications of untreated STIs. Reports that she is not currently experiencing urinary or vaginal symptoms but would just like to get checked out prophylactically. Reports that she and her partner have had unprotected sexual intercourse a few times, denies any other partner in the last month. However, she has had at least a dozen previous sexual partners in the past. To her knowledge, her partner does not currently have any other sexual partners. The patient would also like a referral to an OBGYN for a second opinion on her fertility status. She reports that her previous OBGYN told her that there was less than 10% chance that she could conceive naturally. The patient is unsure as to why this was told to her. Reports that she is not actively trying to get pregnant but would just like to investigate further before it is too late. She states that she is not pregnant because she completed her cycle yesterday. Previous medical history of acid reflux, ADHD, chronic cystitis, overactive bladder, enuresis as a child, and history of chlamydia, gonorrhea, and trichomoniasis. Previous surgical history is that she had a tonsillectomy and an adenoidectomy in 2014. She is not allergic to any food or medications, and right now she's not currently taking any medications. Social history. Patient lives with her mother in Pineville, reports not living in a particularly safe area, but reports that she does not have any fear because she's lived there most of her life. Reports that sometimes she has a tense relationship with her mother and has been kicked out twice and forced to go live with boyfriend at the time or a friend's house. She states that her dad is not in the picture and he has not been there since she was little. She is aware of who she is, but she has not had any contact with him. Denies tobacco or drug use, reports that she does smoke marijuana, however, on occasion when she goes to parties. Patient does not currently have children and has never been pregnant. However, she states that she would like to have kids one day. Patient did not complete high school and has instead opted to receive her GED. Reports that she hardly attended or had good grades in school anyway. She eats a regular diet and has one best friend that she hangs out with frequently and feels supported by her. Patient does not attend church or any other outside activities aside from trying to get her GED. So, family history-wise, her father is alive. He's 44 years old, unsure of medical history. Mother is alive, 44 years, previous history of substance abuse. Paternal grandfather is alive. She's unsure of the age, as well as the paternal grandmother, maternal grandfather, maternal grandmother. They're all alive. She believes that their ages are somewhere in the 70s, she said. And she also reports that she is unsure of their medical history. She has 2 brothers that she is aware that they are alive and healthy. Review of systems. Her general appearance. She denies fever, malaise, chills, or weakness. Head and neck. Denies neck pain or recent strain, normocephalic. Denies blurred vision, photophobia, pain, irritation, infections, or floaters. Admits to wearing like blue light glasses sometimes when she uses the computer. Her ears, she denies tinnitus, pain, drainage, or new or gradual hearing loss. Her nose, she denies frequent sneezing, allergies, bleeding, loss of smell, swelling or drainage. Mouth and throat, denies halitosis, sores, swollen or bleeding gums, denies throat irritation or vocal changes. Respiratory, denies cough, shortness of breath at rest or with light activity, wheezing, chest pain, or pressure. Cardiovascular, denies significant cardiac history, palpitations, lower extremity edema, or discoloration. Endocrine, denies hot or cold intolerance, denies frequent urination, hunger, or thirst, admits gradual weight gain, denies new body or facial hair growth. Gastrointestinal, denies GI history, denies abdominal pain, gas, loose stools, constipation, or blood in the stools. Genitourinary, denies blood in urine, retention, hesitancy, burning, urgency, incontinence, or a foul odor, denies vaginal pain, burning, abnormal discharge, foul odor, itching, or dysmenorrhea. Goes along with genitalia. She denies menstrual irregularity or painful cycles, admits scant amounts of vaginal bleeding due to ending cycle yesterday, denies any suspicious lesions. Musculoskeletal, denies joint pain, stiff muscles or swelling, denies neuropathy. Integumentary, denies skin dryness, lacerations, abrasions, bruising, or lesions. Mental health, denies anxiety, suicidal/homicidal ideations, previous or current suicide attempts, hearing voices, hallucinations, paranoid thoughts, mania, depression, denies trouble concentrating, brain fog, nightmares, or altered sleep patterns. Assessment. Objective, her vital signs are a 98.3 temp, blood pressure of 112/72, heart rate of 58, O2 sat of 99% on room air, respiratory rate is 20, height is 5'3", weight is 216 pounds with a BMI of 38.26. All of that looks great other than her BMI being elevated. General appearance and no acute distress, well developed, well nourished, unkept appearance, patient sitting comfortably on exam table, poor posture noted, developmentally appropriate for age, appearance, alert and oriented ×4. Her mouth, her oral mucosa is pink and moist with adequate saliva production, no lesions noted. Her tongue is midline, smooth without lesions. Gingiva is pink, moist, no swelling, teeth clean with no signs of decay. Patient has 2 silver cap molars on the bottom right and then 1 on the top left. No swelling, redness, or lesions in the throat. Tonsils are absent. Uvula is midline. Swallowing reflex is intact. Lips moist, no fissures, no lesions. Piercing noted to the bottom left lip. Neck, no tenderness on palpation, symmetric, no visible or palpable cervical lymph nodes. Hair, skin, and nails. Skin warm, dry, clean. Mild acne noted to the forehead. Skin color appropriate for ethnicity. No abnormal facial hair growth. Hair on head is evenly distributed and smooth. No lesions or cankers were noted to palms of hands or soles of feet. No bruising, laceration, swelling, or redness noted. Respiratory. Respirations are deep, unlabored, and clear to auscultation in all lung fields. Chest symmetric, no physical deformities. Chest expansion is symmetric bilaterally with no abdominal breathing or accessory muscle use. Cardiovascular, no murmurs, rubs, gallops, rhythm regular, S1 and S2 noted on auscultation. No swelling noted to all extremities. Peripheral pulses are equal and strong, 2+. No JVD noted. No clubbing of fingernails. Abdomen contour is flat, soft, non-tender, no guarding or rebound tenderness on palpation, and no palpable masses. Musculoskeletal, full range of motion noted to all extremities, no joint stiffness, muscle tenderness, or swelling, and walks well unassisted. Neurological, she's AAO ×4, no tremors noted, speech clear, full sentences. Genitalia, the preceptor deemed not necessary due to patient reports of no vaginal symptoms. Psychiatric, eye contact is maintained, answers questions appropriately and quickly, no bizarre thoughts, flight of ideas, stays on topic of conversation, laughing, joking, smiling noted. For lab, we did a urine STD panel, which was a send out. Pending results would be 5 to 10 days. We'll test for chlamydia, gonorrhea, and trichomoniasis. CBC we did was within normal limits. Her WBC specifically were at 6.9, which is not indicative of an infection. UA and urine pregnancy test showed positive trace amounts of blood plus positive trace leukocytes, negative for ketones, nitrites, glucose, protein, bili, or urobilinogen. pH is 7.0, normal is 5 to 8, and specific gravity is 1.025. We want it less than 1.030, and urine pregnancy test is negative. Patient has had an HIV screen test before at a health unit times 1 year ago, which she reports, and she reports that it was negative. Assessment, differential diagnosis. The first one I did would be an encounter for screening for infections with a predominantly sexual mode of transmission, which is Z11.3. I also did A74.9, which is chlamydial infection unspecified, or A54.9, gonococcal infection unspecified. And that would be, of course, when the results came back, if any of them popped up positive. I also did 086.20, which is asymptomatic urinary tract infection, since she has no symptoms at all. What I ended up putting and what my preceptor thought was the best thing to put would be the encounter for screening for infections with a predominantly sexual mode of transmission, which is Z11.3. He said, so we put this because it's not a definitive diagnosis due to pending STD panel. Will take 5 to 10 days according to preceptor. Also, no vaginal discharge or lesions noted, as well as no suspicious lesions inside the mouth or on lips. According to textbook and clinical practice guideline book, approximately 85% of women with chlamydia and gonorrhea are asymptomatic. So we felt that this was appropriate. UA and CBC all do not support evidence of infection. Also, patient is not having any symptoms, urinary symptoms or vaginal concerns today. Plan. The diagnosis is made based on history and presentation. The patient's health history is significant for a previous STI infections and cystitis. According to our textbook and the clinical practice guidelines book, recurrence of STI infection is highly likely in this patient. Patient risk factors for acquiring STIs are sexually active, history of multiple sexual partners, being a partner of someone with history of multiple partners, a brand new sexual partner, lower socioeconomic group, most prevalent in ages younger than 25 years and younger than 20, not using protection, and history of prior STD. And I got that all from the clinical practice guideline book. According to that book as well, STI testing is indicated if they're sexually active and not using any barrier methods without regard to symptoms, and any person requesting screening. Therapeutic. Due to the high risk of reinfection, I will prophylactically treat the patient prior to STI panel results. Will prescribe antibiotics that will cover UTI, gonorrhea, and chlamydia, which are the most common STIs. Prescribed, and she also received Rocephin 1 gram IM once in the office, and azithromycin 250 milligram times 4 tabs by mouth once daily times 1 day. It ends up being 1 gram, which is first line to cover gonorrhea. So I did all of those in order to cover UTI, gonorrhea, and chlamydia. The Rocephin 250 milligram IM once is what is in our textbook, but the preceptor had researched it and found that 1 gram would be better because of the patient's BMI. Teaching and counseling. Finish all antibiotics. Return to the clinic if experiencing new or increased vaginal discharge or odor, dysuria, abnormal vaginal bleeding, new or increased pelvic pain, sores in mouth or sore throat. Inform new partner about the clinic visit and encourage him to go get tested at the local health unit or PCP. It is strongly encouraged to not have sex until STI panels come back negative and partner has been tested as well. Preferably, according to our book, stay abstinent for at least 7 days after completion of treatment, especially with gonorrhea. If the test comes back positive for gonorrhea, must test and treat all sexual partners in the last 60 days without regard to symptoms. Educate regarding correct use of condoms and other barrier methods. Educate complications that can occur from STIs, including cystitis, vulvovaginitis, pharyngitis with oral sex, and pelvic inflammatory disease, among other complications. Educate patients that the risk of reinfection with STIs is an increased risk for HIV infection. Referral, consultation, collaboration, and follow-up. Will make a referral to OBGYN due to patient request, as well as a follow-up with recurrent STI. According to CPG book, women may develop PID and experience infertility if inadequately treated or repeatedly infected. Will call patient with results whether it is negative or positive. Will treat with recommended guideline treatments if she tests positive for something else that we did not treat already. For example, trichomoniasis would be treated with flagyl. If positive, must report to local state health department. Patient will return in 3 months for a retest unless showing symptoms before follow-up. If she tests positive, it is recommended in CPG book that blood testing for HIV and treponema, also known as syphilis, is done as well. If there is resistance to antibiotics, if the patient's positive, referral to an infectious disease specialist will be warranted. The level of billing, have a couple of CPT codes, would be 99213, which is an office visit, established patient level 3, 85027, complete CBC, automated, 36416, which is a capillary blood specimen, and then 96372, which is a therapeutic injection. Thank you so much.